Good evening. My name is Mohammed Mughazi. I would like to welcome you all to the second night of the Watany Web Week. Today, our ophthalmology bedtime stories are actually focused around the retina. And we'll start our program tonight with the Novartis lecture, or the Novartis symposium, if you want to call it. And we have a very distinguished guest, Dr. Magdi Musa, who is going to present us with several cases of CNV and the way to approach them and manage them. So, Dr. Magdi, please go ahead.
Thank you, Dr. Mughazi, for the nice introduction. Thank you for the kind invitation. And let me share my screen. I think you can see it now, right?
Yes.
So my talk today is frankly Lucentis in the management of different types of CNV, and I will present different case scenarios and open for any questions at the end of the presentation. We all know that the most important type of CNV is the neovascular AMD, which is the wet type of age-related macular degeneration. And we all know that the age-related always start dry, but at any stage it can turn wet. Even cases with geographic atrophy, they can develop neovascularization later on in spite of the diffuse atrophy in the central area. Based on the anatomical classification by fluorescein and OCT, which is the gold standard up to now in diagnosing neovascular AMD, we have three types. Type 1, which start under the retinal pigment epithelium, and we used to call it the occult one because it was covered by the retinal pigment epithelium. And in the fluorescein, as we can see in the first one here, first up slide is the late leakage of undetermined source, and the sketch or the diagram showing the CNV coming under the retinal pigment epithelium. Type 2, where the CNV penetrates the retinal pigment epithelium and becomes under the retina. Type 3 start intraretinal and then progress down to encroach on the subretinal and then on the choroid and becomes subretinal, intraretinal, and choroidal lesion. We used to have type 1 and type 2 mixed like this picture, but this is in the old days where we used to use PDT, where we have a predominantly classic, predominantly occult, and it's not of issue these days. Let's go to the third type, which we don't see much, but we sometimes misdiagnose or we see it very late, so we don't properly diagnose it, which we call RAP, or retinal angiomatous proliferation. And the diagram is showing that the membrane starts intraretinal, then goes deep down and start to elevate the retina with subretinal fluid, and then choroidal neovascularization start and connect with the intraretinal component, giving this picture of retinal angiomatous proliferation, which is very late picture, and sometimes the patient presented with this presentation. What is the characteristic of RAP, which is very important because diagnosis of RAP is very important, and we will say that why? Because it's, yes, a sort of CNV, neovascular AMD, but it's 50% happens in Caucasian. That's why we don't see it much in Egypt. It has high frequency of PED. It comes in older patients. It has sometimes hard exudates, small hemorrhages, like vascular component inside the retina, and the natural cause used to be unknown, but nowadays the natural cause is not that good. Most of the recent publications say it's the most common type, ending up with geographic atrophy when you find RAP lesion. And OCT is very diagnostic, and this is a case of intermediate RAP. You see the elevation of the retinal pigment epithelium, you see the cystoid edema, the intraretinal hard exudates, but it's already goes down under the retina. Other signs, when you see RAP very early, you look at the retina, you find hard exudates, which is not that common in neovascular AMD. You find the angiomatous lesion at the level of the retina, not deep down. You can see on fluorescein angiography the intraretinal component. ICG is helpful in most of these cases because you can differentiate between intra or subretinal. And OCTA, which we'll speak about in a minute, is also diagnostic in these cases if we don't afford or we don't have ICG. The fourth type is polypoidal choroidal vasculopathy, which is considered, again, a type of wet AMD, and nowadays they call it different, like macroaneurysmal formation, but we still call it PCV, and it's bilateral. it happens in younger age, sometimes early 50s, in Black, Asian, and Caucasian, mostly Black. Male to female ratio is 7:3, and recurrent serosyngenous detachment. You find huge hemorrhagic RPE detachment. You suspect the polypoidal. It starts in the peripapillary, but nowadays it's not only in the peripapillary area. You can see it in the macular area, you can see it in the periphery, and still in the peripapillary area. And we use nowadays OCT angiography to differentiate these types of lesion, which is very helpful sometimes to differentiate because it's a 3D image. You can see the level of the lesion, you can see the localization of the lesion. Like in type 1, you look at the lesion under the retinal pigment epithelium, so you have to dig down under the choriocapillaris, and you can see clearly at the level of the choriocapillaris when it's type 1. When it comes to type 2, it penetrates the RPE. It is above the level of the RPE, so you can see it clearly at the level of the outer retina. And type 3, which is the RAP, you don't look at the outer retina of the choriocapillaris. On the contrary, you look at the deep plexus, the deep capillary plexus, because as we said, it starts intraretinal. So in the early stages, you can find it like the green area, you can find intraretinal component, and you can look at it on the deep plexus. OCTA is diagnostic in PCV sometimes because it gives us a very good clue, like branching vascular network ending by small polyps, especially if you have hemorrhage like this, elevated retinal pigment epithelium, but you have to be careful where to look because the PCV sometimes causing this huge hemorrhagic RP detachment is small and away or remote from the extensive lesion you see at the posterior pole. And here's a very good clinical case scenario showing a very large hemorrhagic RP detachment, multiple deep and intermediate retinal hemorrhages, and it looks like a CNV. But again, with the help of OCT, we can see that there are multiple elevation of the retinal pigment epithelium with underlying hemorrhage, but knowing where to look, there is a branching vascular network in the macular area and another branching vascular network in the peripapillary area. So this is the cause of PCV, and it's very diagnostic here. And again, if we don't have ICG, like in Egypt now, we don't use it, we don't have the dye, so OCTA can be very helpful in distinguishing PCV from different types of CNV. So my second part of the talk is about anti-VEGF in different types of CNV, type 1, type 2, type 3, type 4, and also I will encroach on 1 or 2 slides for the myopic CNV. I will highlight the role of Lucentis in management of CNV, and these some clinical case scenarios where I use Lucentis and I show you how many injections we need, how do we start, what's the regimen we use. So this is type 1 CNV, as we can see here, the retinal pigment epithelium is elevated and the membrane is under the RPE with overlying sensory detachment and diffuse macular edema. And I used to work on these cases PRN, but nowadays I only work with a treat and extend. So I start with a 3 loading dose. And once the retina is dry, I extend the injection time by 2 weeks interval. And this is very important to have not only line scan, but you have to have the macular map analysis because the central foveal thickness is important. Sometimes the sub-RP fluid is not our aim to flatten, though this case showed almost complete flattening of the retinal pigment epithelium, but this is not our aim. Our aim to dry the macula completely, intraretinal fluid and subretinal fluid. And of course, the macular map can show here that 224 microns in the center is complete dryness after 3 intravitreal Lucentis. As I said again, and this is my way to explain, we are not aiming to flatten the retinal pigment epithelium. So we inject, we follow up by OCT, we can see that the retina is getting dry, the fluid is not there anymore, but not the sub-RP fluid, because the sub-RP fluid is not our aim. So once we reach this stage with a regained foveal contour, no sign of edema inside the retina, no cystic spaces, though there is some sub-RP fluid, because the membrane is always there, it will never vanish. So this is our aim, to dry the macula up and to reach the maximum vision, and this is patient improved from 660 to 69 after 4 injection, and at this time you inject, you extend, and follow up the patient for the next injection. This is another type with cystoid macular edema, and sometimes we say if it's a cystoid edema, huge elevation, Sometimes it's difficult, but it is not. But again, we have to look at the other criteria. Would this patient improve much? Because we can see here that the photoreceptor is distorted, though the foveal contour is regained. And we can see here that the macula is completely dry. And sometimes I use OCTA, as I mentioned before, to see if there is any residual activity. And we can see here the long filamentous dead tree-like vessels, which means that the case is completely dry, though the vision is improved only to 618, but this is the maximum vision we will gain because of the disruption of the outer retinal layers. So again, we should not aim for 6.6, but we should look at the OCT, complete dryness, restoration of the foveal contour. Sometimes OCTA is very helpful to tell you when to stop, and then you have to extend the regimen, extend the injection times, and I always start by 2 weeks and sometimes by 4 weeks. Would it work in huge retinal pigment epithelium detachment and hemorrhage like this? This is a case when I saw it, I said it could be a polypoidal, it could be a retinal pigment epithelium detachment with a huge fibrovascular proliferation. And I have multiple line scans, which I will show you now, but this is a huge retinal pigment epithelium, hemorrhagic one, and multiple elevation at the level of the RPE. And look at the choroid, it's a very thick choroid, though the patient is in the 60s. And this is multiple line scans through the horizontal, oblique, different line scans. And we can see here that complete resolution happens, but we have to be persistent in some cases. So once we look at the patient, we have to evaluate the visual prognosis, the amount of hemorrhage, the amount of edema, because this patient needed 6 continuous injections to completely dry up the macula. And again, the vision, the maximum vision we gained is 618, which is a very good achievement in spite of the starting vision, which was counting finger. And this is a very good achievement, but this is the maximum vision. And again, I insist, drying the macula, knowing the vision, and this is the maximum vision you'll get. So when you treat and extend and the fluid comes back, you know that the maximum vision you will get is 618. So this is your aim when you drive up the macula again, and you would know that these cases, sometimes they need more and more injections to get dry. So don't count on only 3 loading doses and say this is enough. No, you have to do the 3 loading dose and continue monthly until the macula is completely dry. Then you start to inject, to extend the treatment regimen. Type 2 is easier, but I didn't want to show you a very frank type of type 2. I got you a patient of type 2 CNV with proliferative diabetic retinopathy. It's a combined pathology. And this is to show you how the AntiVEGF is the standard of care in these cases. This is a type 2 CNV, as we can see here, changes at the outer retina, plus NVEs in the central area. And look at the OCTA, which will give you an idea. Where is the CNV? Where the red arrow is pointing, and it looks like a leaking lesion, but it's deep down. It's not like the NVE, which we can see temporal to the macula. And we all know that double pathology here means that you have a very high level of VEGF to start with. So after second injection, this is 1 month after the second intravitreal Lucentis, and still we have many edema, though the foveal contour is regained. And this edema is only overlying the CNV, and we have to keep injecting. And this is follow up after another 3 intravitreal Lucentis, still active CNV, as we can see here, based on OCT angio, because we can see that the edema is regressing and the OCT angio showing still activity. And we have to keep injecting till the macula is completely dry, because we are attacking 2 pathologies here, CNV type 2 and diabetic macular edema. And OCTA, again, it's very helpful when it show you how the front is getting smaller and smaller with very low flow. We have to extend the treatment in these cases, but most probably we have to keep this patient for life under follow-up, because it's not only diabetic, it's CNV. Let me treated with Lucentis, starting vision is 20/200, and we can see this is one of the old patients I had with the OCT was old, still with the time domain, and we can see after 1 month after 3 ranibizumab, and the vision is 6/12, and we can see complete flattening of the macula, though the macula is not that healthy as we can see in the fluorescein angiography. As I said, this is a spectral, this is a time domain, very old one. But again, we can still see that the outer retinal layers is disrupted, and this is why the maximum vision is 612. So again, it works in the rat, but we have to take care because these patients nowadays have the worst visual prognosis because they develop geographic atrophy very rapidly. In one of the studies, 62% of these patients will develop geographic atrophy. So we have to be very cautious not to overtreat. Otherwise, we might push this patient into degenerative changes more than helping them of getting rid of the fluid. My last case is polypoidal choroidal vasculopathy. And as I said, we have to anticipate the polypoidal. Once you see a patient like this with huge sub-RPE hemorrhage in the peripapillary area, there is no other changes. This is a 51 years old. As I said, PCV happen in younger age, doesn't have to be very old age. And there is no sign of age-related macular degeneration. There is no drusen. There is nothing there. And the patient coming out of the blue sky, complaining of sudden drop of vision with central scotoma due to this massive hemorrhage. And even fluorescein angiography is not helpful in such cases because we all know that ICG is the clue in these cases. So this is most probably a PCV, and we don't have ICG, so we count on OCT. And this is her fluorescein when she presented in. And I scanned the pictures. That's why the resolution is not that good. But again, there is no much evidence where is the lesion. So this is the multiple OCT line scan. As you can see, the hemorrhagic RPE detachment. But again, this yellow arrows can show the elevated retinal pigment epithelium, which is a double hump, sometimes like the camel, or sometimes they call it like irregular RPE detachment. But again, this is suspecting that there is a PCB down there, and OCT is very helpful, but you need to know where to put the line scans to differentiate between this and the fibrovascular RPE detachment. And this patient was a bit naggy. She started to ask for second opinion. Later on, Lucentis twice before she presented again to me with this picture, and we can see this yellow pigment is dehemoglobinized blood, which start to resolve, but still the fovea is overwhelmed by the subretinal hemorrhage, and we can see line scan through the hemorrhage. Another line scan showing where is the polypoidal. This is the polyp. That's why I insist every time on different line scan to see how the polyp is working, and I know that the hemorrhage will take time and it will resolve. And this is the OCT A showing barely the choroidal and the neovascularization, because sometimes if the hemorrhage is massive or the hemorrhage is deep, it will obscure the elevated retinal pigment epithelium and you can barely delineate the polyp. 1 month post the force injection, and we can see that the hemorrhage is going away, and we still see the polyp. We can see it down there. Another line scan through the retinal pigment epithelium elevation. And 1 month, this is for the force injection. We can see that the flow inside the polyp is getting much better. And this is 6 months later with no more injection, and she's stable. But as we can see, there is complete destruction of the photoreceptor layer. That's why when you have a massive hemorrhage like this, sometimes if the patient would agree, sometimes we inject gas to displace the hemorrhage. Sometimes we do vitrectomy and inject under the retina, because once the hemorrhage is long standing, it will destroy the outer retinal layers. Though the vision is 636, but still the patient is not that satisfied because the central vision is almost gone. Though the hemorrhage is gone, you can see in the parafoveal area, but none of the central vision has been regained, and the quality of vision is poor in such cases. We can see here how the flow is very low at the level of the outer retina under the retinal pigment epithelium, but still, as I said, the prognosis is not that good because long-standing hemorrhage, especially the subretinal one, involving the fovea, will affect the quality of vision because of the destruction of the outer retinal layers. So again, intravitreal anti-VEGF can work, but still we need more and more injections. Here is Lucentis in myopic CNV, and we all know that the myopic CNV is completely different from different types of wet AMD, the type 1 or 2 or 3 or 4, because myopic CNV has a very good natural course. Sometimes one injection will do the job and you don't need any more. And sometimes you need to follow up this patient at the first 3 months monthly. But once the edema is gone, you shouldn't keep injecting this patient. As I said, it has to be treated PRN from the beginning, one injection, one by one, Some of the patients need only one injection, some of them need two, and then you follow up this patient for years and you find out that they will never need another injection. So again, myopic CNV is completely different. The natural course is better, and it's always type 2, never type 1, because it is always above the retinal pigment epithelium. And we have to be very meticulous in deciding when to stop treating this patient, because as I said, it's misleading sometimes if you keep injecting this patient, because the scar will not go away and the membrane is decreasing in size, but the vision sometimes is not regained, because we all know that in myopic patients, other factors like myopic macular degeneration, disrupted outer layers will affect the final visual outcome. So my take-home message is multimodal imaging. We have to use multimodal imaging to differentiate different types of CNV, and it's for better evaluation, confirmation of final diagnosis, because as I said, some of them are very bad natural history, like the RAP lesions, and some of them need more and more injection. Some of them have combined pathology, so all the imaging modalities should be used, and intravitreal anti-VEGF is still the standard of care in the management of any type of CNV, and Lucentis is an effective in the management of different types of CNV. Thank you so much for listening.
Thank you very much, Dr. Magdi. Always informative and very elegant presentation as always. We don't have questions from the audience, but I have a question for you. You being an authority on OCT angiography, how do you see the role of OCT angiography in decision-making in treatment or retreatment of different types of CNVs? At the moment, of course.
Yes, telling you the truth, I don't use much of OCT angiography, though I have it, but nowadays I use it once I find in the other eye a suspected lesion in the initial diagnosis. If I find the frank CNV in one eye and I look at the other eye, I found flat or irregular RP detachment, I use OCTA in these cases. But in the final decision, sometimes after repeated injection, as I showed, not at the initial presentation. I do it for my interest, but for the message, no, you shouldn't do OCT angiography for all cases from the beginning. It is not recommended up to now, even in all the studies. OCT and fluorescein as a baseline is enough, and in the follow-up OCT, standard OCT is enough. But OCTA, if you suspect a lesion in the other eye, if you're suspecting polypoidal, as I show you, and you don't have the ICG, and if you are injecting the patient many times and you find out that there is no way you get all the changes in the macula, and you do OCT and you find long filamentous vessels, you should stop injecting this patient or extending the treatment based on that.
Okay, thank you very much, Dr. Magdi. Any other questions from the panel?
Thank you, Dr. Magdi. Really very informative and, as usual, entertaining and informative. Perfect presentation. Thank you.
Thank you.
So, do you have questions, Dr. Magdi?
Thank you, Dr. Magdi. It's very elegant presentation as usual.
Okay, thank you. I think we left time for the next presentation. You should start. I'm done, and there is no question, so you can start the other presentation, because I know there is a lot of bedtime stories we like to hear before we go.
Okay, thank you very much, Dr. Magdi, and hope to see you again in our Watany meetings.
Inshallah.
Thank you very much.
Thank you.
So we can start the Retina panel now. Dr. Stauro, Dr. Rania.
Hello, Dr. Muhammad.
Hi. So we need to start. We will start by you, right?
Okay, fine.
Okay. Can you at the beginning give us an idea of what we're gonna present and how we're gonna present it, and how what's the role of the panelists and the role of the speakers?
Basically, we have interactive cases discussing the role or different approaches in management of vitreous hemorrhage with very common diseases we see in everyday practice, like proliferative diabetic retinopathy, CNVs, microaneurysm, how to tackle these diseases, whether to tackle it surgical or medical, or maybe a combination. And I believe the panel will help us to shed the light to reach the proper management.
Okay, so you go ahead. You'll start with PDR, I guess, right?
Yes. I have to share the screen. Okay. So my presentation is about management of proliferative diabetic retinopathy with vitreous hemorrhage. I have few cases to discuss different scenarios. Before I start, I have to revise few quantitative data. 1 in 11 adults have diabetes, and the prevalence of diabetic retinopathy is around 34%. Diabetic retinopathy is the leading cause of vision loss among working population, and most of vision loss could be prevented by early detection and intervention. So basically, it's a serious blinding disease we see in everyday practice. In 2020, we can manage this disease through different approaches. We have laser photocoagulation, which is the standard of care. We have AntiVEGF, pars plana vitrectomy, and maybe lots of combination treatments. My first case here is a male patient. He is 32 years old male patient. He's a banker, a demanding person, very meticulous. He came complaining of right floaters for 2 weeks. He's insulin dependent for 24 years. The vision is 0.7 in the right eye, 0.8 in the left eye, nothing remarkable in anterior segment examination. He came with that fluorescein. We can see new vessels on the desk, elsewhere in both eyes, and there was a dispersed vitreous hemorrhage in the right eye. Macula was dry with preserved foveal contour. So my first questions goes to you, Dr. Muhammad, how to tackle a patient like this one with dry macula, young male, and having a dispersed vitreous hemorrhage with good fundus view. Would you go for injection, PRP, combination? How would you treat him?
Well, usually those high-risk PDR patients, especially the young ones, they can bleed at any time. So this patient obviously had no previous laser treatment. And the view is not that bad, but again, it's not that good. So I think at that specific moment, laser would be a little bit of a challenge. So in those patients, I usually give an anti-VEGF injection and wait for a couple of weeks. Usually hemorrhage is clear, not because of the VEGF, but because you can give time to the hemorrhage, it will clear. And then I'll do the laser. That's how I approach a case like this.
What about you, Dr. Sharif? Dr. Sharif?
Can you repeat the question because I was disconnected for a moment?
If you have a young male patient with proliferative diabetic retinopathy and dispersed vitreous hemorrhage, would you go for PRP treatment or maybe an injection before laser treatment?
For this particular case, we're talking about this case.
Yes.
Yes, there is a mild haze, but from the OCT, you have a clear view of the macula. So if there was a dense vitreous hemorrhage, probably wouldn't have been able to get a decent OCT. So I usually withhold my anti-VEGF treatment if I can do a PRP. And I usually, of course, with a little bit of haze, you have to go with a higher power. But again, you can do this under local anesthesia. So I would do a PRP and see how things will go. This doesn't mean that using anti-VEGF is not the correct choice. Both are correct. But I would opt to start with a PRP, and in some cases it might be enough. Okay, you can combine it with PRP, or you can just use anti-VEGF and then wait. Both are correct, but I myself would go for a PRP under local peribulbar anesthesia without anti-VEGF treatment.
Thank you, Dr. Sharif. Moving to the next slide. Actually, this patient had an intravitreal injection and bilateral PRP treatment divided on multiple sessions. And here we can see fluorescein 2 months post-laser treatment. Best-corrected vision improved to 0.8 in the right eye, 0.9 in the left eye, with regression of new vessels. OCT shows dry macula, and OCT angiography shows areas of macular ischemia with enlarged phase and again dry macula. And my question now goes to Dr. Maged Mikhail. Now you have a patient with regressed PDR, ischemic macula. Would you like to add another treatment or just follow him up? How frequent would you like to see him? And would you follow him only by examination or maybe adding an imaging modality?
No, I just follow up the patients. There is regression, complete regression of new vessels. I just follow up the patients, no further treatment, and I would like to see him after a couple of months or maybe 3 months, or if a deterioration of vision occur during this follow-up period. But at that moment, I just follow up the patient.
Okay. And the patient actually was very happy until he came back 4 months later with recurrent floaters in the right eye, and the vision was stable though. We ordered fluorescein angiography, and here we can see a recurrence of neovascularization in both eyes and dispersed vitreous hemorrhage again in the right eye. However, OCT scanning showed dry macula in the left eye and this shallow neurosensory detachment in the right eye. Would you like to ask for more imaging, Dr. Moghazi, or you can assess how to manage this patient?
Well, for me, of course, like the beginning of this case, I said I will inject AntiVEGF, wait maybe a couple of weeks, and then for the hemorrhage to go away, and then in that situation, then I would be tightening the laser. But with this traction in the right eye, I think I withheld from injecting these patients, and I will definitely not rush for surgery. I will tighten the PRP all around. You can see skip areas in the posterior pole here, and maybe I will inject and do laser in the other eye, tighten the laser in the other eye. But I would give some time for the hemorrhage to resolve in the right eye and just tighten it and close follow-up of the detached area.
Would you change your decision if you saw the multimodal imaging with this shallow, well-demarcated neurosensory detachment and line scan demarcating an area of retinal break infranasal to the extramacular area? Would this change your treatment, Dr. Moghazi?
Well, this is different at the moment because now I can see also there is subretinal hemorrhage, and in that picture you're showing us the multicolor picture. You can see it's encroaching into the macula inferiorly. Now, in that situation, I think I would go for surgery in that patient.
What about you, Dr. Sharif?
Let's go back to can you go back to the fluorescein, the slide before this one?
This one?
Yeah, the one before. This is blank. Yes. So can you just bring this one. Yes, the fluorescein, this one. Yes. So the point is, the first fluorescein that you did after the PRP, how long was it after the anti-VEGF injection?
It was 3 months post anti-VEGF injection.
Because to me, it's sometimes, I don't know the opinion of the other panelists. It's to me, if you do a full scatter PRP and you get a complete regression, it's very rare to get new vessels after this. So my opinion is that whoever did the PRP did a relatively good PRP, but I think those new vessels were concealed by the anti-VEGF treatment. So when you did the fluorescein, it looked as if it's completely regressed. And once the effect is gone, these new vessels appeared. So I would have been more aggressive with my PRP from the first time. I would have gone a little bit more central than the one shown here. Of course, not so central, but again, I think those areas were not treated at the beginning. So maybe a full scatter, that's why I don't inject at the beginning, because I want to see the effect of the PRP alone, because sometimes it's concealed by the anti-VEGF treatment. So I'm not sure if these are new vessels that appeared after the PRP was done, or these were already there, but were concealed by the anti-VEGF treatment. So I don't know what's the opinion of Dr. Moghazi and Dr. Magid about this. Do you meet cases once you do a full scatter PRP that you get new vessels after that, or this is I haven't seen it in my practice. I don't know what's your input.
Well, I personally see cases of recurrent new vessels elsewhere after PRP, but like in those cases, very close to the posterior pole, and you know this area is some kind of somehow precious. So you don't really want to do a lot of laser at the very beginning, especially if this is a very young patient. So I think I agree with you that probably those skip areas of laser at the very beginning and the treatment was not that aggressive that led to this appearance. But usually, yes, I face those cases, especially when the patient is treatment naive and I do complete scatter with or without the anti-VEGF treatment. And usually in down the road in 3-4 months, I can see the recurrence of neovascularization like this.
What kind of machine was used for this laser? Is it the pattern laser?
Yes, the pattern laser.
Okay, so I'm not an advocate of pattern lasers in PR.
We all know that, Dr. Sharif. And I believe you have a point.
Look at the scars, Dr. Sharif. They are scars at the end of the day. So if
I like big scars. Like big scars. Again, it's a good PRP. I'm just saying that I have a feeling that always the conventional laser 500 microns laser spots going full scatter in the sense of really full scatter. Usually it kills all the new vessels. But again, yes, you might have more central NVEs in some of those aggressive patients, and sometimes you can get them over the fovea. And that's we need vitrectomy. So I'm just brainstorming with you the different patterns of PDRs. Okay.
I have to confirm the point of view of Dr. Sharif that anti-VEGF treatment may mask neovascular leakage on fluorescein. So if our patient was taking anti-VEGF closely, he may look regressed. However, we can see afterwards that it was the effect of anti-VEGF. So about that patient, I believe Dr. Maged Mikhail, you agree that he needs a vitrectomy because of the retinal break, right?
Yes.
Actually, this patient had the pars plana vitrectomy with Dr. Moghazi, and 6 weeks later, he came with best corrected vision improved to 0.8 in the right eye and 0.9 in the left eye. Supplementary PRP was added to the left eye, of course, and I brought this case to highlight the importance of checking for retinal breaks if we have extrafoveal vitreoretinal traction. Now moving to another case, he's a taxi driver, 48 years old male patient complaining of right floaters for 12 months with progressive loss of vision. Now the vision in the right eye is 0.05, 0.7 in the left eye, and fluorescein angiography, as you can see, shows signs of high-risk PDR. We can see hemorrhage, crescent hemorrhage, subhyaloid hemorrhage here, an early PDR in the left eye. OCT shows almost dry macula in the right eye, and the hemorrhage is obscuring the view in macular scanning. Supratemporal minimal edema in the left eye. The patient was scheduled for intravitreal anti-VEGF injection, followed by PRP in both eyes. We can see regression of neovascularization in the left eye. It was conventional laser this time, and we can see regression of new vessels. Maybe we can appreciate residual intravitreous hemorrhage. The macula is almost dry in the left eye. However, we can see this band of traction within the perifoveal area. Meticulous scanning of that area shows localized neurosensory detachment with minimal hemorrhage. My question goes to Dr. Maged Mikhail. If you have an extrafoveal traction like that one, would you encourage the patient for vitrectomy or just follow him up?
Any traction inside the macular area, I usually encourage the patients for surgery to avoid more destruction of the photoreceptors and gain more visual prognosis for the patients. So any traction inside the arcades, even if it's extrafoveal, but the inside the arcades, I mean in threatening the fovea, I usually encourage for surgery.
It's on the borders. Here is my line scan. I need to show you the previous scan. The macula is almost completely dry and attached.
No, I think it appears that outside the arcades. So at the time, you change the.
Yes.
Yes. Okay. No, it is nearly outside the arcade. So I follow up the patients and may add extra laser, tightening the laser burn, and follow up the patients. If the traction's exceeding towards the fovea, I will go for surgery.
What about? Would you encourage him to have further laser, or just follow him up, or encourage pars plana vitrectomy?
No, if the traction as I see outside the arcades, this is nearly outside the arcades, so no need for interventions early. So I follow observations with tightening of laser and follow up if the traction exceeding or invading the inside the arcades and threatening the fovea, I will go for surgery.
Do you have a different approach, Dr. Moghazi?
No, I will just do the same.
What about you, Dr. Sharif?
مين عامل ليزر ده؟
هقول لحضرتك في المستشفى.
لا ليزر كويس، يعني شايف ان الليزر سكارز كويس. يعني انا بس بقول ان sometimes يعني at the beginning when you showed the picture of the right eye, the first impression we thought of vitrectomy because the hemorrhage was quite significant. And the view even with the OCT was hazy. But again, with the follow-up picture, you can see that most of the hemorrhage has gone and probably it is resolving. So this again shows that PRP can still play a role and you don't have to rush into surgery from the beginning. And I believe that this patient, 100% I'm sure that he did the laser under peribulbar anesthesia because you wouldn't have been able to deliver this kind of laser without good anesthesia with the vitreous haze. So with this extramacular traction, I agree with Dr. Magid and Dr. Moghazi to follow this patient. Maybe I would have added a little bit of tightening the lasers in the skip areas away from the traction. Nasally, I think there are some areas that probably were covered by the hemorrhage, but I will avoid the area where there is fibrovascular proliferation. And follow the patient since the macula is on, so the patient probably is enjoying pretty good vision.
Actually, that's exactly what happened. The patient kept regular follow-up. We can see the difference between the images in red rectangle, and 8 months later, the traction is almost stable and the hemorrhage is resolving. However, the patient is still complaining about vitreous floaters. So I brought this case to assess the risk-benefit analysis of vitromacular, extrafoveal vitromacular traction. Would we go for surgery or just follow up? And I believe you have shed the light on that issue. Another case, she's a lady, 69 years old female patient who came complaining of left floaters for 2 weeks. She had previously bilateral phacosurgery. She's insulin dependent, diabetic for 33 years with vision 0.7 and 0.6. We can see her fluorescein. She has more or less mild to moderate non-PDR in the right eye. We can see scars of previous focal laser treatment. We can see vitreous haze and vitreous floaters and dipooling here. She was diagnosed somewhere else as having proliferative diabetic retinopathy. And she was even scheduled for intravitreal AntiVEGF injection. When she presented to our hospital, a meticulous examination showed an acute PVD with infraretinal, nasal mid-peripheral vitromacular traction and a retinal break. We could assess it even by OCT line scans, and she was treated by laser photocoagulation surrounding the retinal break, and after 3 months we can see complete resolution of the hemorrhage with reattachment of the area of retinal break. I just brought this case for my younger fellow to consider other causes of vitreous hemorrhage in patients with diabetic retinopathy. We don't rush to diagnosis. We have to consider other causes of vitreous hemorrhage, especially if the other eye has a mild to moderate diabetic retinopathy. So what do you think, Dr. Muhammad? Have you seen cases misdiagnosed as proliferative diabetic retinopathy and have another diagnosis underlying the hemorrhage?
Yes, of course, I've seen this, but actually your case is very interesting because the hemorrhage is not covering the whole retina. So you still have the chance to good examination of this patient, and it would have revealed, of course, just seeing the fluorescein angiography, you consider this a case of PDR and hemorrhage, and you would go ahead and maybe inject these patients. But the importance of examining those patients, especially those patients where the hemorrhage is not covering the whole retina, is really important, like you highlighted. If you have a patient with dense vitreous hemorrhage, this is another story. Of course, you look at the other eye. If the other eye doesn't give you a clue, I mean, if the other eye has no diabetic changes at all, then you would suspect that maybe the hemorrhage, the dense hemorrhage in the other eye is maybe due to a venous occlusion, maybe due to a retinal tear, and so forth. And you need to investigate and weigh the weight versus the intervention, the early intervention with the patient. But your case is a great example of the importance of good clinical examination, not relying only on investigations.
Thank you, Dr. Moghazi. Now moving to the fourth case, we have a dentist. He is very meticulous person, 51 years old male patient, complaining of left drop of vision for 6 days. He's insulin dependent for 11 years. The vision in the right eye is 0.8 and 0.16 in the left eye. Fluorescein angiography shows signs of proliferative diabetic retinopathy, both eyes, massive retinal ischemia in the right eye, and premacular hemorrhage in the left eye. OCT line scans shows minimal edema and coverage of the macula with pre-retinal hemorrhage. And now my question goes to Dr. Shrifin Babi. What about this patient? Would you like to just give him a PRP laser treatment, go for injection, or maybe a surgery for the left eye?
Left eye?
Yes.
Injection, pre-surgery by 1 or 2 days, vitrectomy. Prompt vitrectomy. No other choice.
Dr. Magid?
The same, injection, and after a few days, surgery.
Dr. Moghazi, that's your case.
Yeah, this is what I did. Yeah.
Okay, now I leave you with very elegant surgery by Dr. Moghazi, illustrating the prognosis of surgical management in those cases. And please, Dr. Moghazi, narrate the video.
Well, this is actually not the same case. This is a very similar case. Again, a proliferative diabetic retinopathy patient whose first presentation with this dense subhyaloid hemorrhage. You see here it's covering most of the macula, and there is a chunk of fibrovascular front just temporal to the macula along the arcades. The video is not playing, Rani. Oh, yes, now.
Okay.
So I'll not go through the technique itself, but in those patients, you can have sub-ILM, sub-hyaloid hemorrhage, or both, and sometimes you can have also subretinal hemorrhage. In those PDR patients, young patients with presenting with such a presentation. It's just cleaning up the hemorrhage, which can take quite a lot of time, and you have to be careful because sometimes it's really added to the underlying retinal surface. In that case, it was only subhyaloid. It just the ILM was stained already with the blood, so I didn't need to stain it, and it was removed. And then just more cleaning up of the surface of the retina, and then just air fluid exchange and laser. And I think this patient visual acuity improved to 0.9 after the surgery, I guess. Thank you, Rani.
A very elegant surgery and beautiful laser marks, Dr. Moghazi. And yes, you are right, the vision markedly improved in 6 weeks. We can see vision 0.6 in the right eye and 0.5 in the left eye. He's very happy. He is a dentist and has to go back to his work. And I brought this case to highlight the importance of discussion of possible prognosis with our patients. My last case is a worker. He is a 41 years old male patient who came complaining of drop of vision, counting finger in the right eye and 0.5 in the left eye. Fluorescein shows proliferation, fibrovascular proliferation surrounding the arcades, pre-retinal hemorrhage in the right eye. OCT shows a premacular hemorrhage, maybe an extra foveal traction in both eyes, encroaching into the parafoveal area supranasally in the supratemporary, in the left eye. My question goes to Dr. Shrifin Babi. How would you manage a patient like that? Would you go for PRP, combination, maybe vitrectomy?
Well, this is a challenging case because this is a case that can go both ways, but usually those cases will need surgery sooner or later. Even if you start with PRP, you will end up doing surgery in most of those cases. The right eye, I would go for surgery from the beginning. Of course, it's a very active disease. So I would inject again pre-operatively by 1 or 2 days, and then do a vitrectomy for the right eye. The left eye is more challenging because the macula under the thickened posterior hyaloid is flat and dry with a preserved foveal pit. So probably this left eye has good vision, it's at 0.5. So
Yes.
I would cautiously do a PRP and follow this eye. Maybe it will evolve into more traction over the macula, and maybe not. Sometimes these new vessels become ghost vessels, and the macula stays okay. So the right eye, I would go for surgery preceded by injection, and the left eye, I would go for a PRP without injection.
Thank you, Dr. Sharif. Actually, our patient refused any type of surgery and preferred receiving PRP, and he disappeared for a few months and came back with that view. We can see complete resolution of the premacular hemorrhage, regression of the new vessels with residual leaking vascular front in this area. And as you mentioned, there is progression of traction in the left eye. So I believe the situation is reversed now. Vitrectomy is more likely to be done in the left eye, and we can follow up the right eye. What do you think, Dr. Sharif?
Well, he's a lucky patient.
Yes.
But still, the right eye still have active new vessels. So you don't know what will be the future for this patient. So he might surprise you with a vitreous hemorrhage or a subhyaloid hemorrhage sometime down the road. The left eye, the macula is starting to be affected, and there's a little bit of traction involving actually almost reaching the center in the left eye. So probably the vision is now worse than 0.5. So I think the left eye is a candidate for surgery, but probably he's refusing surgery in all circumstances. So I don't know, he will agree.
Yes. What about the right eye? Would you add the PRP laser treatment, or still encourage him to have the surgery?
I will just observe this eye. Maybe I might add a little bit of laser on the nasal side, but I still see that there's a good scatter all around. So maybe if there is some skip areas, it's not really apparent on the montage. But again, if there is some spaces on nasal side, I might add a little bit of laser or just observe the right eye, especially the macula is okay, and see how. But the left eye, I would go for surgery. So the right eye, probably I would observe.
Thank you, Dr. Sharif. Actually, our patient had supplementary PRP for the right eye and disappeared before having first perennial vitrectomy for the left eye.
You'll come
And
again.
I brought this patient to illustrate that, as you mentioned, it's a long road we have to go through with our patients. And now I go to my take-home message. There is no shortcuts when it comes to proliferative diabetic retinopathy management. It's a long road. Each time we have to check vision, the state of the right eye, if the patient is compliant or not. We have to weigh cost against benefit. If the patient is aphakic or pseudophakic, his age, retroretinal traction, his lifestyle. It's a long road to preserve the vision of those patients. And finally, I would like to thank you for your attention.
Thank you, Dr. Rania.
Thank you, Dr. Rania, for a very nice collection of cases. I would like to invite Dr. Trace Kamel for her presentation.
The laser, Rania, you didn't tell me.
في المستشفى اقول لحضرتك
الميديكال ريتنا كونسلتنت بتاعت المستشفى تشريف
كده طبعا عشان اقول لها برافو تسلم ايديكي. طيب مفيش مشكله يعني.
اتفضلي يا دكتوره تريز.
سامعني؟
Yes.
Okay. Good evening. Thank you for allowing me to join in with you. Today I'm going to talk of retinal arterial macroaneurysm, which is known in literature as RAM. I'm going to start by the...
Your voice is not clear. You have a
voice is breaking.
Mic.
Okay, let me try...
Your voice is cutting.
Can you hear me?
Yes, we can hear you, but the quality of the voice is it's like as if it's cutting. You're talking from the earpiece, the headphone.
Okay. Is this better? Is this better?
Yes,
Yes,
this is better.
Okay. I'm going to classification, and I'm going to start with the...
علي صوتك شويه تريز.
أعمل إيه؟
علي صوتك.
علي صوت شويه.
Okay. I'm going to talk of the classification, and I'm going to start with what Lewis had described in He described retinal arterial microaneurysm into three types. The indolent presentation of the exudative, which we commonly see presentation of macroaneurysm with a small area of hemorrhage near it, with exudation by OCT. We can see the cystoid edema and sometimes fluid. And this is actually of a female patient who is in her 60s, and she is hypertensive and dyslipidemic. So we literature that females are more likely to have macroaneurysms above 60, and we also see it in hypertensive and patients. The second, the more acute type, is the type that suddenly, and it would cause what we call hemorrhage, which is subretinal, intraretinal, preretinal, and vitreous hemorrhage. This actually conceals the macroaneurysm, and you can suspect it by having a dense patch of hemorrhage along an artery. That would make you patient has macroaneurysm. And the last type is the quiescent type, where the patient is not complaining, but on routine exam, the patient was coming in for to check for his diabetic retinopathy, and was detected. And this is known as a quiescent macroaneurysm. This patient had very good vision. So the first question would go to Dr. Shrif. If a patient came to you and you saw this macroaneurysm, how would you manage?
Nothing.
Okay. Dr. Mohammed Mughazi and Dr. Megan Nakhail, do you have other alternatives? Would you do otherwise?
In quiescent aneurysm, no need of treatment because the majority of these macroaneurysms spontaneous resolution will occur within few weeks.
Yes. Dr. Mohammed, would you do otherwise?
No, the same.
Okay. So we have to deal with the vascular risk factors in this patient, the hypertension and the dyslipidemia, and otherwise we follow up this patient. The majority of patients will follow a benign course of thrombosis, fibrosis, and spontaneous resolution, and asymptomatic RAMs can be observed every 6 months until involution occurs. This is another patient, and this is one of the associations with macroaneurysms. Sometimes along the artery where the macroaneurysm has developed, you would have a branch artery occlusion. This is a patient who had a macroaneurysm and also a branch artery. We can see the delayed arterial filling, and we can actually see the areas of coagulative necrosis along the temporal macula with macular edema. So my question again would go to Dr. Shrif. If this patient came to you, how would you deal with this patient? Would you inject this patient? How would you deal with this patient?
So this is a patient having a RAM or a retinal arterial macroaneurysm with macular edema, correct?
Yes,
now,
and artery occlusion.
Already he has an artery occlusion. Okay, interesting. Yeah. So because sometimes if you do laser to this patient, you may induce artery occlusion.
Yeah.
So, usually this aneurysm will self-thrombose after that, and probably the edema will go away by itself. But if you want to hasten the resolution of this edema, I would try injection of AntiVEGF, and I have some experience in some patients that surprisingly did very well with the injection. I'm a little bit cautious with laser treatment because in the previous era, when we do lasers, I have met patients, maybe 1 or 2 patients that developed branch arterial occlusion, even if you do a laser around the aneurysm, just touching its wall or a perianeurysmal area. So I would go for AntiVEGF injection, or I would just observe the patient, and this edema will go within weeks or months. But I may inject these patients.
Does anyone have a different opinion? Would want anyone agree with injection, or would you follow up the patient?
Well, in that particular patient, I guess laser is not an option at that particular location, but I would consider laser if it's a little bit further away from the center of the macula. And as for the injection, I have tried injections in those cases that sometimes they work, sometimes they don't. But like Dr. Shrif mentioned, once the macroaneurysm has thrombosed in, those edemas usually disappear on their own.
Dr. Megan, would you do the same?
I may try to inject in these cases, but the coexistence of branch retinal artery occlusions may holding me to take this decision. So I prefer in this case to follow up.
Okay. So this patient actually was followed the resolution of all the macular edema after 6 weeks on his own without having any injections. This is another case, and this patient came in presenting with dense vitreous hemorrhage. And so he was, he had a parsman vitrectomy, and on table, he was found to have an associated ischemic old branch vein occlusion. And the reason I'm bringing up this slide is because I want to highlight the point that sometimes you can have a macroaneurysm and another association that can occur because they are both predisposed by the same vascular risk factors such as hypertension. This surgery was actually done by Dr. Shrifin Baby, and he found the macroaneurysm, and he also found the areas of ischemia that he treated with laser. So my question is, if this patient, if you had a patient with vitreous hemorrhage and he had this extrafoveal subretinal hemorrhage, would you care to deal with this subretinal hemorrhage as away from the fovea, or
No.
we just leave it? Yes.
No, we leave it. We only care if it is subfoveal. And
Yes, exactly. This is the message.
There is no point because this blood will go away and the aneurysm will self-thrombose. So this patient has a combination of both, as you just mentioned, ischemic branch vein occlusion associated with RAM. And this area, I didn't even treat the retinal artery macula. I left it by itself. I just left this area and it went away by itself.
Yes. So if you have subretinal hemorrhages away from the fovea, we wouldn't care to deal with it because, as Dr. Shree said, it will eventually thrombose away. I got out because I wanted to share this with those interested in retinal imaging. And this is a finding that was described as microvascular angiopathic changes adjacent to the retinal arterial microaneurysm. And occasionally we can have, this is a patient who is diabetic, but we can obviously see that we have very dense telangiectatic vessels. We have a cluster of microaneurysms and areas of non-perfusion. And actually this was described as being a compensatory response to the presence of the macroaneurysm in this area because of the affected blood flow and hypoxia. And sometimes when we do retinal imaging and we see this, we might start to consider that this patient probably has a vein occlusion in this area, but this is not the case. This is a kind of compensatory response. And now this is another patient. This patient comes in with a very obvious macroaneurysm, and this patient has a dense circinate hard exudates. Obviously, we know that this is not the appearance of a diabetic macular edema or the common vein occlusion that we see. So if a patient came to you with this fluorescein and he had this OCT, how would you deal with this patient? Dr. Mughezi, how would you deal with this patient?
Well, it's hard from these photos to get a clue of what's going on here. But this is actually, looks like retinal detachment rather than edema or subretinal fluid. Did you trace it to the periphery? Did you see where it goes?
Actually, this patient has both. This patient has some traction, and this patient has leakage that is related to the macroaneurysm. The patient has both.
All right. So, I mean, the OCT looks obviously as a retinal detachment rather than edema. And I would be very skeptical. I need to examine the periphery, see if there is a break or not. If there is no break in those patients, again, I would either observe or give an injection, but still injection in those patients, in my hands, they don't give enough of resolution of the edema. Usually it resolves on its own.
Okay, Dr. Shree.
Well, the first thing, what pathology are we dealing with? Let's assume that this is an exudative edema. There is no rhegmatogenous element. So this is an exudative edema of the macula. And this can be seen by the massive exudative response that is in the posterior pole, whether nasal to the disc or even involving the upper macula. Now, the lower retina looks to me relatively healthier than the superior retina. So probably we are dealing with some sort of a vein occlusion. I don't see a definite macroaneurysm in this case. Maybe this reddish area there, possibly it could be a macroaneurysm, but it doesn't really show on the fluorescein clearly that this is a macroaneurysm. So if this is some sort of a vein occlusion, because you can see that the vein, the superior vein to the nasal side is a little bit tortuous and dilated compared to the lower vein, as far as I can see. But I would inject this patient with AntiVEGF to see what is the response of this patient. But I cannot tell that this is purely a case of macroaneurysm, particularly that you can see leakage in the superior macula.
I agree. I believe it's a combined vein occlusion, macroaneurysm, and traction. Yeah, I agree, because they have all, but the circinate hard exudates around the area where we can see the pre-retinal hemorrhage or the intraretinal hemorrhage shows that there's a localized area of leakage in that area. I believe the patient has both. But still, my question is, would you inject when this patient has this amount of traction?
This traction is not really that thick traction, and again, we are always afraid of traction if there is fibrovascular proliferation. I mean that there is new vessels. The concept of having a membrane, whatever, if it is a posterior hyaloid, the epiretinal membrane, this is a silent membrane that does not react with anti-VEGF treatment. The only ones that we are afraid of that may induce more traction or cause breaks in the retina, if the formation of new vessels, like in PDRs, or new vessels in ischemic branch vein occlusion. But in this case, this is just either a posterior hyaloid or an epiretinal membrane.
Well, actually, this patient had several injections and ended up developing a full thickness macular hole and then had a partial plano vitrectomy. That's how the scenario of this patient went.
Again, full thickness macular hole could be from the chronic edema. We cannot really tell. But again, would you do surgery for this patient? I wouldn't really rush in such a case. I don't know if my other colleagues would go for this, because again, we have to make sure that this is a purely tractional element and not an exudative response to some sort of vein occlusion. Again, we have to see that the frames are a little bit narrow. I would like to see more of a wider frame to see the upper.
Again, I got this pictures retrospectively, but even the peripheral frames didn't show areas where we could have a break. And actually, yes, it showed more of a combined vein occlusion with the small microaneurysm in these photos with the traction.
I'm not convinced that this kind of traction is enough to induce this kind of macular decay.
Oh, okay, so if we saw this kind of traction, we're safe to inject. Is that what we're saying?
I might give him a chance with an injection and see.
Okay. So okay, in the interest of time, I'm going to move on. This is a very case of microaneurysm that we probably all see in our clinics. This is who is 70 years old, comes with an exudative microaneurysm. And my question would go to Dr. Magid. What would you do to this patient if he showed up in your clinic?
This patient has exudative microaneurysm. This is exudation or hemorrhage trace, please. Previous slide, please. Yes, this is mild hemorrhage underlying the microaneurysm. In this case, I do pause. I inject anti-VEGF. Beside a very faint laser, I will do around the microaneurysm, very low power, long durations, one spot. So I can occlude the microaneurysm as well as I inject anti-VEGF and within a week of the laser.
Okay, Dr. Do laser or you would just inject?
I would just. Are you asking me or Dr. Mouazi?
Yes, I'm asking Dr. Sharif. I'm asking you.
I would try to do an injection and see how the response.
Dr. Mohammed, you do the same or you'd have laser?
I'll do both, laser and laser.
This patient had first injection, then the patient showed the resolution of the edema starting to resolve, residual edema, and the vision had improved. So would you go on injecting or would you just follow up the patient?
I myself would inject again.
Okay, Dr. Mohammed, Dr. Magid, inject again?
Yes.
Okay, so you got injected and we can see by the second injection, this patient has showed marked resolution of the macular edema. And this is the role of AntiVEGF in these patients. It decreases vascular permeability, it reduces nitric oxide, causing vasoconstriction and allows involution of the microaneurysm, breaks down the balance between the occlusive and the fibrinolysis process, so it can help clearing vitreous hemorrhage. And also it induces a pro-fibrotic switch, which enables the fibrosis and the involution of the RAM. This was a study conducted on bevacizumab, and actually they recruited patients with exudative microaneurysm. They gave them one injection of bevacizumab, and then they followed in PRN. And they said that the average number of injections was 1.42 injections for this patient. And they said at 1 month, there was a significant difference between the group that they treated and the group that they didn't treat. They divided the patients into a group that was treated and a group that was observed. And they found the patients who were treated at 1 month showed significant better visual acuity and central subfield thickness. But at 3 months, the patients who were treated and those who were not treated were equal as concerning the central subfield thickness and the best corrected visual acuity. And this was the conclusion they drew, and they said that bevacizumab can help hasten the resolution of macular edema and hemorrhage secondary to RAM. And the next part of the presentation would focus on the number of injections. There was a study that was used treating patients with RAM using intravitreal ranibizumab, and actually they mentioned that most patients would do quite well with just one injection to clear the macular edema and hemorrhage over a follow-up period of 7 months. So let me direct a question to the panel. Dr. Megid, would you, in a patient who has a retinal arterial microaneurysm, would you give him the once monthly injection for 3 months, or you go a baseline then PRN?
No, as I told you before, in macroaneurysm, I usually prefer combined faint laser with injections, and in the majority of cases, I need just one injection.
Okay, Dr. Muhammad, would you do the same?
Actually, no. What you mentioned, by the way, on the mechanism of action of anti-VEGFs in those patients is not clear. So I just like to test the water, they say. So I inject one injection and see the response. I still do the laser. But if I see clear signs that the macroaneurysm is already closed, I don't do the laser. I just give one injection and see the response. If there is a good response and there is residual edema, I might be encouraged to inject more. Or let's say I'll go PRN. If there is no response from the first injection, I usually would observe.
Okay, Dr. Sharif, how would you go with anti-VEGFs?
No, we have to make clear that retinal arterial macular edema is not like diabetic macular edema. We don't have controlled trials to guide us to do what is the best treatment. So if one surgeon does laser or the other one does, inject once or 3 doses or a combination of both are all correct. So we don't have really a protocol to treat these eyes. But again, most of those eyes, once they become active in the form of either exudation or edema or even a little bit of minimal hemorrhage, they will self-thrombose, and this edema and hemorrhage will go away in a matter of few months, by the way. And if the same patient that you showed earlier, if you just did nothing and the patient came after like 6 months, you would find that the macula is dry. We only inject because we want to minimize any damage to photoreceptors. My observation in those patients that sometimes 1 injection or 2 injections are quite enough. So a PRN approach, as suggested by Dr. Magid and Dr. Mughazi, is the one that I always adopt. Most of those patients don't require more than 2 injections, usually. And the temporary relation between the injection and the resolution of the edema shows that anti-VEGF treatment does have an effect on those patients, and the patient does feel an improvement in the short period after the injection. Yeah.
So the next case would stress on when would I start. This is a patient who comes in with a macroaneurysm, very intense macular edema and hemorrhage around the macroaneurysm. And the patient actually had 1 ranibizumab. You see that the patient has almost completely resolved except for some subretinal fluid and some small cystoid spaces. So Dr. Megid, would you inject again, or you just leave this patient alone and he's going to resolve?
I will inject again.
Dr. Sharif?
Since there is still fluid, yes, probably the patient is still complaining, I would give him another injection and observe and follow.
Dr. Mughazi, did you inject again? Okay. So actually this patient didn't have another injection, came back in 3 months, as we mentioned, and the patient actually had complete resolution of the central macular edema.
Self-resolution is part of the natural history.
Yes, exactly. This is another patient that has a massive macular edema from a macroaneurysm and subretinal fluid. This patient has a, I'm going to show you the color pictures later. This patient, 1 ranibizumab injection. Then the patient comes back. This is the second picture. The patient has resolved some resolved macular central surface thickness has decreased actually, but actually we can see quite a good amount of fluid still in the subretinal space and intraretinally. So the patient is subjected to another ranibizumab injection, and maybe not very classic indirect laser treatment, but actually the patient had some indirect laser treatment. The patient came back in 6 weeks. And he had decreased macular edema, and then the patient came back, had another ranibizumab injection, and showed a resolution of the macular edema. Another patient came with a very huge macroaneurysm, as we can see, And this patient actually was advised, because there was no fluid, central macula, as you can see, is dry, and was advised not to have any treatment and just to go for follow-up. Actually, the patient went elsewhere. And the patient showed up after 1 year because the patient developed a macroaneurysm in the fellow eye. But as we can see, the patient had, by somewhere, another eye doctor elsewhere, a direct laser treatment to the macroaneurysm. So aims to seal the macroaneurysm, as Dr. Magid said, a large spot size, medium to long duration with the lowest possible power, but we have to keep in mind this is not without complications. You can have actually a rupture, or which can induce hemorrhage, or you can have an arterial occlusion. And actually we have mixed reports regarding the visual outcome, saying that 16 to 25% of these patients would thrombose after a direct laser treatment, and this is quite similar to what would have happened anyways if you didn't have the laser. The indirect laser treatment are confidently burns of shorter duration, medium reaction around the lesion to the incompetent that are believed to be part of the cause of the macular edema, and the rationale behind is decrease in oxygen demand to nearby retinal tissue, which is going to reduce blood flow and pressure within the artery that would induce involution of the retinal arterial macroaneurysm. And to more of hemorrhage here, this is a patient with subhyaloid and sub-ILM hemorrhage related to the RAM. So Dr. Shreve, if you had a patient who came with a macroaneurysm with this kind of multilayer hemorrhage, how would you deal with this patient? Would you have a YAG or a vitrectomy?
Well, this is a good candidate for YAG hyalodotomy, because you have a thick hemorrhage, mainly, of course, covering the center of the macula, ignoring the fovea with a fluid level, and it is sagging down to the inferior macula. And usually this is a sub-ILM rather than sub-hyaloid, by the way.
He has two. He has one. He has a level of sub-ILM, and he has another level of sub-ILM. He has the two levels.
So, but I would consider doing a YAG hyalodotomy. Of course, one of the issues is sometimes when this blood escapes into the vitreous, sometimes it may cause a vitreous hemorrhage that may cause floaters to the patient. But again, if it is a young patient, how old is this patient?
Actually, this is a picture from literature. This is not a patient I came across. This is a picture I picked from literature.
Yeah. So I would probably discuss the options with the patient, but again, you can get away with a simple YAG hyalodotomy without subjecting the patient to a vitrectomy. And I have good results with such subhyaloid hemorrhages, whether it is due to Valsalva or RAMS, or even sometimes in few cases of diabetic patients after doing a good PRP. So yeah, I would go for a YAG hyalodotomy.
Would you tell us how you titrate your laser in this case?
Well, usually I pick an area that is quite thick and it's quite inferior, and I usually use the 3 mirror, the central lens of the 3 mirror, because I want to have good stereopsis. And I just titrate my laser and I adjust the YAG on the posterior, and I just go for a certain power, and usually I start with a low power and start to see the response. Usually at one time you prick the posterior hyaloid or the ILM, and the blood goes away into the vitreous, and you can see it coming out. You can also do it with the argon laser, and with the argon laser what you can do is that you can do again in the inferior thickened posterior hyaloid or the ILM. You can do several spots of medium power argon laser, 200 microns, so that you kind of stretch the ILM. And within this circle, you go with a 50 micron argon laser, and you go high with the power, like you go like 800 or 900, and then you go there so that you puncture the ILM and the blood. So if you don't have a YAG laser, you can do it again with the argon laser.
Okay. Dr. Muhammad, would you do otherwise?
I personally would go for surgery. Of course, YAG can work, but the problem is if this is related to macroaneurysm, like you've shown, and we know that macroaneurysm is associated with a high incidence of subretinal hemorrhage, then I would be expecting that under this area of subhyaloid or sub-ILM hemorrhage, I might be facing another layer of subretinal hemorrhage. So I would go for surgery from the beginning in that case.
Dr. Magid?
Sure, I will go for surgery. Of course, YAG laser may do something, but in this case, I usually prefer to go for surgery, especially as Dr. Muhammad said, we in the majority of cases we can see some layer of submacular hemorrhage. And in these cases, I usually prepare a vial of TPA beside me intraoperative, because I can find the area or maybe more than layer of submacular hemorrhage beside the periretinal hemorrhage. So I prepare to inject TPA in these cases during surgery. So in this case, I usually prefer to do surgery and prepare a vial of TPA beside me if I need it.
Okay, so I'll go on in the interest.
How about doing a preoperative OCT? Would that help, Therese?
The OCT may help up to the point where the hemorrhage is dense. If it depends on how dense the hemorrhage is. If it's dense enough to cause shadowing, then probably it wouldn't really help us to detect the subretinal hemorrhage. But occasionally, yes, we probably can detect the subretinal hemorrhage under.
Yeah, I might recommend doing also an OCT just to see if there is subretinal hemorrhage as well. If the hemorrhage, the pre-retinal hemorrhage, is not that thick enough to prevent getting a picture of the subretinal space. So this means
sometimes the hemorrhage may be so severe enough, making shadowing effect behind.
If it's not.
Cannot differentiate.
If you want harm to order one.
Okay, so some surgical cases. This is managed by. Talk about this.
Should be out after this.
بليز احنا مش سامعينك خالص. Okay, but مش مهم the video keeps cutting يعني. بس the idea of this case is that it presented with dense vitreous hemorrhage. The patient is not diabetic. There is no nothing in the other eye to give us a clue of the cause of the hemorrhage. Ultrasound was not conclusive, except for there is no retinal detachment, and there was no any drusen's in the right eye. So I thought this could be very well a case of retinal arterial macroaneurysm, and I discussed the option with the patient to just give her a week, 10 days to follow up. If the hemorrhage doesn't clear enough to see what's really going on, we go to surgery, and this is what happened. We went to surgery, and lucky enough, she was lucky that there was no hemorrhage underneath the retina, but it was all extramacular subretinal hemorrhage, and all what was covering the macula is sub-ILM and subhyaloid hemorrhage, like the video has shown. This patient, of course, regained all of his vision, all of her vision. Actually, there was no also neither harder exudates in the macula. So, and of course, what I wanted to ask here, do you do anything for the macroaneurysm during the surgery? So, Sharif, do you do laser over the macroaneurysm intraoperatively?
No, I usually don't, because it will self-thrombose.
Yes, okay. I didn't do neither. So this was about this case.
This is another patient who came with best corrected visual acuity of 360. So we can see that this patient has a premacular hemorrhage and subretinal hemorrhage. Actually, why it's up is to that when the patient has retinal hemorrhage, an option of the vitrectomy to clear out the subretinal hemorrhage using TPE can be helpful. This patient actually didn't take the option of surgery and left and came back with, as we can see, organized hemorrhage with complete destruction of the outer and actually thinning of the inner layers. And this is because subretinal hemorrhage actually yields the poorest visual outcome in this patient. It causes a mechanical barrier between the RPE and the photoreceptors, and there is iron-related toxicity. And actually, it was mentioned that permanent damage can occur within 2 days to 2 weeks. So it looks like here we're tight with time concerning when we can intervene in subretinal hemorrhage. So what is the optimal time, Dr. Sharif? Would you decide to go in and operate your patient? When would you think this is good timing and this patient is going to have a good visual outcome? And when the patient comes to you, you would say that it's all over, you can't help him with TPA?
Well, the sooner the better. If I see a patient that has a submacular hemorrhage within a day or two, I would operate next day or same day if it is possible, provided TPA is available, because there's a problem of availability right now. But if the patient comes with a hemorrhage more than 2 weeks, I would be skeptical to do surgery, because by that time damage is already set. We don't have a real cutoff. Usually they say after 1 week, by the way, because the shielding effect on the photoreceptors would be maximum by 1 week. So I would be more generous to say 2 weeks, but more than that, I would be skeptical to do any surgery. Other surgeons have reported good results with surgeries up to 1 month after the hemorrhage, but I don't think it would be beneficial. So I would go a week, maximum 2 weeks. More than that, I wouldn't do any surgery. It's too late.
Okay. Patient, this is Dr. Shrif, this is your case. This is a patient who had a quiescent. He had AMD and PCV in the other eye, but this is not the case. What we're talking about is the small macroaneurysm that was detected by the OCT scans. This patient had quiescent macroaneurysm, came in a year. This is a whole year of quiescence. Then came after 2 months, and the macroaneurysm started to increase in size, and we can see some exudation. And actually, this patient had a fluorescein, and we can see that the macroaneurysm is starting to show some leakage. Surprisingly, this patient came in 1 month after the fluorescein had developed dense subretinal and pre-retinal hemorrhage. And at that point, Dr. Shrif decided to have a surgery.
So this is the presented to me. Before that, he wasn't my patient.
Yes, exactly. So would you like to comment about the video?
So this patient had a combination of both subretinal and sub-ILM or subhyaloid hemorrhage. I don't know if the video is not playing. Now it's playing, but it is slow. But anyway, the multi-layered hemorrhage is very typical of retinal arterial macular aneurysm rather than AMD. Usually AMD, the hemorrhage is purely subretinal or submacular. So, so this patient had a combination of both sub-ILM hemorrhage and subretinal hemorrhage. Now, the subretinal hemorrhage was partially involving the fovea. So I did a vitrectomy, removed the posterior hyaloid, opened the posterior hyaloid and the ILM, and removed the pre-retinal blood. Now, the question is, I was really asking myself, I already had TPA ready on my table, whether to do submacular detachment with diluted TPA with a fluid air exchange, or just leave the patient. So I decided to go to dissolve this blood clot with subretinal injection of TPA. Now, the main bulk of the hemorrhage was superior. So there wasn't much of a space to go into the inferior retina. Usually I prefer to go to the inferior retina so that to create a pocket inferiorly. Now, this is the problem with submacular hemorrhage that is superior. If you try to inject, usually when the bleb increases in size, usually the area of least resistance is the fovea. So some of those patients may develop small macular holes. And actually in that patient, I felt that there is a little bit of blood coming from the macula, despite that I was very cautiously injecting the diluted TPA in water. So I continued my injection to create the submacular bleb in order to displace the blood away from the macula. But since I suspected that there is a macular hole, I was not operating with an OCT. So I decided also to peel the ILM, so that if there is a macular hole, I would want to close after the surgery. And I stained the ILM. The video is so slow, but I'm just talking faster than the video. But anyway, I peeled the ILM. Interestingly, when I stained with the brilliant peel stain, I found that all the central ILM is gone, because actually the blood that was there was sub-ILM. So when I removed the sub-ILM hemorrhage, I removed the central ILM, the central area. So I completed my the peripheral ILM peeling, and I put an ILM graft over the macula. And I did a complete fluid air exchange and put him on 20% SF6. So not a partial fluid air exchange as we do in cases of submacular hemorrhage with TPA, because usually we leave a space for the pocket to move. So what I did is a complete fluid air exchange, 20% SF6 infusion, and a face down position. One thing is to displace the blood, which did work in this patient, by the way, and also to close the macular hole. So probably we can skip the video because it's not working. Therese, you can show us the post-operative pictures. So so this is the blood before. Actually, we didn't have a photo picture before. This is the intraoperative, and this is the post-operative.
This is the 1 month post-operative images, and we can see the macroaneurysm. And the patient actually has almost a dry macula. And this is a patient 1 year after. And we can see the area where the graft was placed at the site of the macular hole. So the question here was the optimal time of intervention. Actually, we have already touched on that. This is the last case, and this case is an 85-year-old female patient who came with a vision of counting fingers 100 centimeters. We can see also the multi-layer hemorrhage detected, and we can actually see the macroaneurysm where you can see along the vessel in the infrared cutting through and seen in the B scan. And so Dr. had the same.
Well, this is a very similar case to Dr. Shrie's case we've just seen, and there's a very similar technique and actually a very similar complication. I had a very small macular hole while I injected the TPA, but I know in this patient I already removed the ILM because most of the blood was in the sub-ILM space. I really didn't bother to use a graft of ILM because the hole usually it's just a vent. I mean, it's not an actual hole, but it's like Dr. Shrieff mentioned, it is a weakest point, so the blood is venting through the fovea. I did not use any kind of graft, of ILM graft or flap, and I just used air in this patient's face down position. And actually, I didn't see the hole in the post-operative pictures. You can skip the video and show the post-operative pictures.
Okay.
احنا نقسم من RM على فكرة.
غالبا من عندي أنا مش من RM.
So the hole again is closed. I didn't use any flaps or any grafts, and because I already removed all the ILM because the hemorrhage was sub-ILM, and the visual acuity actually markedly improved. Yeah.
So the management of a associated with TRAM, they showed that patients who came with vision of an average vision of 20/200 over a follow-up period of 18 months after having surgery with a TPA showed an improved vision of 20/40. So I believe these patients have a good chance when they show up early. So in conclusion, when you manage a patient with TRAM, please consider managing the vascular risk factors with the internal medicine doctor. And as we mentioned, there is no consensus regarding the management of symptomatic cramp because it depends on the presentation and complications. Exudative lesions typically respond well to relatively few numbers of intravitreal anti-VEGF injections. And lastly, submacular hemorrhage patients can be treated with vitrectomy, TPA, and tamponade. Thank you.
Thank you very much, Therese. Now we'll go straight forward to Dr. Dina Badar for her presentation. Because we're already running out of time, but we really enjoyed the discussion and the cases.
لا, I'm still here. Thank you. Dr. Maghazi, are we going to address the questions later?
Please, just go ahead and with your presentation because we were tight on time.
Okay. All right. Okay. Let me do that. Okay. All right. You all see the presentation? All good. Okay. So I'm going to discuss today cases that will have retinal hemorrhages, but they are not AMD. I'd like to first thank Watany Retina team. They've all been great. We work as a team. We do everything together. So I'd like to extend my thanks to everybody. So the aim of the presentation is to discuss the less common causes of vitreous hemorrhage in elderly patients, the clinical presentation of each entity, and the associated findings, the multimodal imaging and treatment options. These are retinal pathologies in which the vitreous hemorrhage can be the presenting symptom. They affect the age group between the 50s and the 90s. So this is a big age group, but they are not AMD with no known history of trauma, and it's our role to find a clue. So this is basically the mind map of what I'm going to say. If it's not AMD, so is it PCV or polypoidal choroidal vasculopathy, or PHCR, which is peripheral exudative hemorrhagic chorioretinopathy. So the age group makes a difference. For younger patients, we think PCVs, and for the elderly ones, we think PHCR, and the right dead in the center between 65 and 77, this is when you think more of AMD. The PCV patients, they come in with scotoma with the dim or blurred vision, while the PHCR are asymptomatic. PCV, they have better vision than AMD. They have more common complications, and you consider anti-VEGF treatment, because we're going to discuss the modalities. While with PHCR, they have better prognosis, and hence they resolve spontaneously. So let's start with entity number 1, polypoidal choroidal vasculopathy. We're going to share 2 cases with 2 separate clinical scenarios. The case number 1 is a 62-year-old female patient. See, it's younger than your average age for AMD. She came in with actual drop of vision in the left eye that she's noticed accidentally 3 weeks back. The anterior segment examination was unremarkable, and the vision in the right eye was 0.7. You can appreciate the multiple drusenoid PEDs in the center of the macula, while for the left eye, the vision is 0.15. And so we see this elevation of the pigment epithelial in the center of the macula with multiple deep yellow lesions surrounding the actual big detachment. The patient also had some subretinal hemorrhage. The right eye, you know, pretty unremarkable. We expect those drusenoid PEDs to be hyper autofluorescent and to stain on fluorescein angiography. And we do a B scan, we can see those drusenoid PEDs with actually quite a thicker choroid than you would find on AMD. This is one of the clues. While in FA, we can see this lesion in mid frames. I wouldn't call them early frames really, because this is a choroidal pathology. So you would expect them to be in early frames, but they do not appear on fluorescein angiogram. They appear on ICG-A, which is not available in Egypt. So we're going to discuss the fluorescein angiogram. So you see those hyperfluorescent lesions that actually progress into a broader lesion as the angiogram goes with pooling and masking by subretinal hemorrhage. When you do OCT for those patients, you see those massive PEDs with those hyper-reflective bulb-like lesions on the undersurface of the RPE. Sometimes you see this notching, which is pretty pathognomonic for this particular entity. And again, the choroid looks pretty okay. So let me tell you this, there is no examination for an AMD patient without looking at the choroid. Please, if you have an OCT machine, just take a look at the choroid. It will tell you pretty much a lot of things you need to know. So this patient had subretinal fluid, has massive pigment epithelial detachment. Dr. Moghezi, how would you proceed?
How would you proceed? I think I mean, I don't know, you didn't show the OCTA of this patient, right? But it's obviously a PCV, okay? So, and okay, there is subretinal fluid and this huge PED. I guess I will start by injection, of course. We have nothing to do more than this.
Yes, that's the only available option on the Egyptian market, agreed. But so let me go to Dr. Megan Mikhail. Would you load or would you go one injection and then re-image?
I usually start PRN from the start. If a complete resolution from the first injection, I continue to second one to confirm the absorption of fluid. So at least 2 injections at first, not loading 3 doses as usual, but I start from the start. I start treatment from start PRN.
All right, and Dr. Sharif, any particular choice of agent?
Well, usually. If you have a massive PED like this, I would prefer to use aflibercept rather than ranibizumab, not because I like Bayer than Novartis, but and I have no financial interest, but because it has been shown that aflibercept has a 20% more ability to go into the choroid more than 20 times than ranibizumab. So when I have a choroidal lesion, like for example CSR or PCV, I would go for aflibercept or Eylea as my primary choice.
All right, excellent. So this patient had presented to us, and this actually answers Dr. Mughazi's question. She presented to us in 2015, so that was before we acquired an OCTA machine. This patient, she received loading AntiVEGF, which was at the time was bevacizumab, and we can appreciate the flattening of the pigment epithelial detachment with those polyp-like lesions still on the undersurface, and she still has subretinal fluid. So I think, would we all agree that we continue to inject?
Yes.
Okay, excellent. Patient received a total of 8 intravitreal injections until we got to February 2016. Remember, her presenting vision was 0.15. Her vision right now is 0.2. Not a lot of, even if the OCT is doing well, the vision is not catching up as much. The subretinal fluid has resolved, the pigment epithelial detachment has flattened. Dr. Mughazi, continue injection or wait?
I would wait at that stage. There's no intraretinal fluid, no subretinal fluid. The PED is not my concern at the moment. I will just follow up in this patient.
Cool. Very good. Then that's the first, one of the first things we need to say. So the sub-RPE fluid, we do not go after it. That's what you mean, right?
Usually resist.
No,
excellent.
It will not add anything if you flatten the PED, not add anything to vision.
And yes, okay.
Good. So, but the patient did receive another injection, and she came in with sudden drop of vision. She went down to hand motion. So we did the B scan, the retinal's in place, patient has vitreous hemorrhage, thickened choroid. Her treating physician at that point decided to go for conservative treatment for 6 more weeks until it was no longer possible. Dr. Sharif, can you walk us through the...
So this is the point where the patient was referred to me, resolving organized vitreous hemorrhage. And then when I looked at the previous scans, as Dr. Dina showed, was previously diagnosed as AMD, and from the findings intraoperatively, I diagnosed her as a PCV from the previous scans and also from the intraoperative findings. So based on the fluorescein that was done at the beginning before the vitreous hemorrhage developed, I decided also after removing the vitreous hemorrhage is to do thermal laser to the leaking points. There was one supranasal that was above the disc, and a few points that were above the fovea. So this was guided by the first fluorescein angiogram that was done several months ago before she developed the vitreous hemorrhage, the first FA that she did at the presentation. So again, thermal laser is one of the modalities that can be used in cases of PCV, in addition, of course, to PDT, which is not available. So I kind of invested the chance that I'm inside the eye, I can do the laser. So I did my laser based on the fluorescein. And at the end of the surgery, I injected ranibizumab, which was the only agent that was present at the time as an augmentation to the surgery. We removed the visually significant hemorrhage, we did thermal laser, and we did an injection of anti-VEGF for these patients. So sometimes, and this is also very classic of cases of PCV that develop vitreous hemorrhage. Sometimes develop vitreous breakthrough hemorrhage is a very common entity in addition to sub-RPE hemorrhage.
Dr. Sharif, intraoperatively, you chose to leave sub-RPE and subretinal hemorrhage, right?
Well, sub-RPE hemorrhage is not an indication to dislodge. Actually, you don't want to go under the RPE. We only work on subsensory hemorrhage. Sub-RPE hemorrhage, we shouldn't do this. Because that's why it's very important when you have any cases of AMD or whatever pathology that you do, I do an OCT because I want to know the level of the hemorrhage, whether it is in front of the RPE or above the RPE or it's below the RPE. If it's below the RPE, this is a hemorrhagic RPE detachment. You don't want to touch this by surgery. But if it is in front of the RPE, that's the one that you want to dislodge by subretinal TPA injection. So in this case, there was no indication to play with this sub-RPE detachment.
So if you don't have an intraoperative OCT, would you recommend getting immediate preoperative OCT images?
Well, intraoperative OCT might be beneficial, but the important thing that if there is a subretinal hemorrhage, you should have also available the TPA on table, because the TPA is not always available. And actually, when you order now TPA, you find difficulty to get it now from pharmacists. But anyway, in this case, the main aim was to remove the vitreous hemorrhage and to resolve this visually significant vitreous hemorrhage. But based on the previous OCTs, the previous fluorescein, it was mainly a pigment epithelial detachment. There was no subretinal hemorrhage. So there was no place for TPA in this case. And that was seen very well during the surgery as well. So there was no role for TPA.
All right, thank you, Dr. Sharif. Yes.
Need to go faster a little bit because yeah, already, and we still have another presentation. Okay.
All right, sure. So we have another case. This is a 62-year-old male who presented with a drop of vision in the right eye for 1 month. He was under treatment for systemic hypertension. And if you look closely, just by examination, and this is the importance of examination inside the clinic, if you look, then you will see a big lesion that is creeping under the retina and the RPE. We have sub-RPE and subretinal, so we have multi-layer hemorrhage superior to the disc, and subretinal hemorrhage extending to the macula. We also have those elevated brown lesions. On the other eye, we see the drusenoid PEDs. When you did the FA for the patient, same thing, mid-frames, hyperfluorescent lesions that stain as the angiogram progresses. This is a patient who he has subretinal hemorrhage in the macula, in the right eye, and the subretinal hemorrhage and fluid related to the lesion superiorly. Left eye looks okay, 0.8 drusenoid PEDs are expected. OCT pretty okay, intraretinal pigment migration doesn't worry us. Patient again received single intravitreal AntiVEGF, and he had this breakthrough hemorrhage. The OCT was actually done, and you can see that the pigment epithelial detachment is still elevated, still has subretinal hemorrhage and subretinal fluid. Dr. Mughazi, how would you proceed from that point? Vision hand motion.
It's a very similar case to the one you've just shown us, and I will give it a week or 10 days for the hemorrhage to resolve. If not, I will go ahead with the surgery for this patient. And in this patient, maybe I would use also subretinal TPA. I'll make it ready. If the hemorrhage has not been there for more than 2 weeks, I will go ahead with subretinal TPA as well.
All right. So the patient actually received his treating physician at that point chose to wait. He received 4 more intravitreal injections. The vitreous hemorrhage was still there, and the B scan was unremarkable. And vitrectomy was offered if vitreous hemorrhage did not clear in 1 month. In 4 months, this is what happened. The patient came back with a fibrosed lesion surrounding the disc, extending to the macula. And there's this scar with elevated nasal part and dry overlying neurosensory retina. So this is what we're saying. We're saying that it's either patient goes through with vitrectomy or they can resolve on their own. Now, a little bit of didactic about PCV, which was first described in 1982 as being a bleeding syndrome. The histopathology is branching dilated vascular channels. Hypoxia is implicated in the pathology, polyp-like aneurysmal dilations, and that's why you will find the name in the literature changing from PCV to aneurysmal type 1 neovascularization with less granulation tissue than AMD. The lesions grow and they become leakier. Clinically, how can I suspect those cases? They usually have branching vascular network. They're usually more orange, and they're usually more nodular in appearance than your average AMD, and they can present with massive submacular hemorrhage or vitreous hemorrhage. ICGA is diagnostic, although not available in Egypt. It shows those hypercyanescent polyps at the border of the lesion with the branching vascular network as the ICGA later in the frames. Now, I would really like to stop at this slide and talk about OCT for type 1 neovascularization or PCV. What we're looking at is usually an elevated finger-like projection from the RPE onto the retina we can find some notching like we see here, or a flat pigment epithelial detachment, something that we call a double layer sign, usually a creeping branching vascular network underneath it, and a large pigment epithelial detachment with those sub-RPE dimples, sub-RPE grape-like lesions, which are polyps, with subretinal hemorrhage plus or minus bleeding. Again, these finger-like projections, and the choroid usually looks thickened underneath it. This is a patient from literature who had submacular hemorrhage at presentation. Patient had those large pigment epithelial detachments in the macula and has undergone vitrectomy, submacular TPE injection, and bevacizumab injection. Okay. The role of OCT angiography. So OCT angiography sometimes could show the aneurysmal dilations, although it's been known to be too turbulent to appear on the angioflow, but it can actually delineate the branching vascular network under the RPE. Note also always note that the choroid is thickened. Now this is a patient that we saw recently in the hospital. Note that there is a cross between the pathology of PCV and CSR. So there's hyperautofluorescence of the RPE in the macula, extending inferiorly tracking sign like you see with the CSR. This patient had this flat pigment epithelial detachment with a creeping vascular network underneath it. When you segment to the part between the Brooks membrane, the slab between the Brooks membrane and the RPE, and when you segment to see the polyp, you can actually see some flow inside the polyps. So the polyps can be seen in some cases, but not all cases. So don't depend on seeing polyps on OCT angiography. And if you don't see it, then B scans are more than enough to delineate those polyps.
Dina, can we go a little bit faster as well? Because we only have like 10 to 15 minutes more. Dina froze.
انت كملتها يا دكتور محمد. ده اللي هو البيت تايم ستوريز، فانت يعني يو هيبنوتايزر.
طب ايه
نديها دقيقة واحدة، ما كانش نعملها فيتريكتوم.
You tucked her into bed.
لا she's froze فعلا.
خلاص طيب I think she covered most of the topics.
طب احنا دكتورة رانيا can we go ahead with the last presentation please لغاية ما دينا ترجع؟ دكتورة رانيا
Okay. Can you see my slides?
Yes, please. Go ahead.
So my last presentation is about hemorrhagic CNV. We have seen medical management case presented by Dr. Magdi Moussa, another approach, the surgical approach in the cases Dina has shown us, and I have only 3 cases. My first case is a female. She is 81 years old patient. She came terrified, complaining of sudden drop of vision in her right eye. Her left eye is lost after multiple AntiVEGF injection. Her best corrected vision is 0.1 in the right eye, counting finger in the left eye. And you can see the OCT showing fresh subretinal hemorrhage and fibrovascular PED with a tiny break. So basically, she's a single-eyed old lady with a fresh hemorrhage. How would we treat it? Would we go for anti-VEGF treatment? Photodynamic therapy is not available in Egypt. It's not an option. Maybe surgery, combination therapy. How would you treat this patient, Dr. Mughazi?
I would go ahead with the surgery in this patient with the submacular hemorrhage. I wouldn't like to leave it until it clots. So I will go ahead with the vitrectomy and subretinal TPE in this patient.
Do you agree, Dr. Sharif Mbabi? You have the same approach? Or you give a chance for anti-VEGF?
This is quite a thick submacular hemorrhage. Do you have color pictures for these patients?
I have a color picture in surgery. Not a true color picture.
Because OCT only can sometimes be deceiving. I always see the color picture because it shows how thick is the blood. Is it all blood or is it blood and fluid? This is also important to know because it doesn't look that hyporeflective that we see in really massive submacular hemorrhage. So, but again, if there is blood, I would consider surgery like Dr. Mughazi mentioned.
I believe you agree, Dr. Magid, right?
Yes, that's what I do actually.
So this case is basically treated by Dr. Magid Mikhail, and he shares the elegant surgery with us. Please narrate the video, Dr. Magid.
Yes, this is the case as Dr. Rania show us that is a case of two types of hemorrhage, subretinal hemorrhage and sub-RBA hemorrhage. And in this case, I decided to go for surgery to do a vitrectomy with TBA injections under guide of the IOCT, which helps me so much to inject TBA directly in the subretinal hemorrhage inside the lesion itself and away from sub-RBE to avoid any injury or trauma to the RBE. There is no rule of TBA in the RBE space hemorrhage, as Dr. Sharif said before. And at the same time, I active aspirated the liquefied blood using the same needle of injection under guide also of ISOT, as we see in the previous image, that complete collapse of the hemorrhage under the retina. And I left the media at the end of surgery almost clear. And we can see, Rania, the image post-operative.
Yes. Yeah, we can see great improvement with vision improving to 0.5. However, we can see still there is an element of activity, subtle subretinal fluid. And my question is to Dr. Sharif Mbabi, after a marvelous surgery like that and maybe a recurrent activity, would you go for more injection or you just leave a case?
Actually, those cases, I would continue injecting them on a treat and extend basis because those patients sometimes they may rebleed again. We treated the complication, but we did not treat the main pathology because we did not remove the CNV. So what Dr. Magid beautifully did is to remove the blood that was collected under the retina, but still we have the active CNV. So in this case, you may opt to continue injecting the patient afterwards. So I would go for a treat and extend protocol, trying to increase the periods between injection and the other.
Dr. Mughazi, would you change the frequency, maybe the dose of anti-VEGF treatment, or you go for the standard regimen?
No, my standard regimen for treatment, which is PRN. And the thing is, in those patients, sometimes after you do the vitrectomy and everything, they don't just recur, but they become sometimes very aggressive. And sometimes the hemorrhage recurs under the retina after a few months or few years even. And so the take-home message from this case that the activity is not related to the vitrectomy or the vitreous surgery. So you have to keep an eye on those patients, whether by treat and extend or PRN, and bring them every 4 weeks for observation. So I would do that.
Thank you. And I think you are paving the road for the next case. My second case is a 75-year-old female patient. She came complaining of left drop of vision for 2 months. She's hypertensive, and the vision in the right eye is 0.5 and 0.3 in the left eye. We can see dry AMD, and we can see active CNV with hemorrhage in the left eye. OCT angiography confirms presence of vascular front. We can see it here with overlying shrim or subretinal hyperreflective material in both line scan of the OCT and OCT-B scan. My question goes to Dr. Magid Mikhail. Would you like to approach this patient in a surgical manner or just injection?
Just injection, of course. This is very mild hemorrhage, so I inject and follow up the patients after injections if we need more injection or not, based on PRN protocol.
So the patient actually received 4 monthly injection with complete regression of the vascular front, as you can see here. But unluckily, she came back a few months later with sudden drop of vision and this massive submacular hemorrhage. Again, do you agree that we have to go for surgery this time? The other eye is seeing very well, actually.
Still.
Yes, it's an indication for surgery. This is massive submacular hemorrhage. I would like to have an OCT of this patient, see how it looks like. You have one.
I'm sorry, I don't actually. But the patient went to surgery and the vision improved after surgery to 0.05. We can see the macula dry, and we can see here the shallow rosinoid PEDs. However, she came back 10 weeks later with another episode of massive submacular hemorrhage with drop of vision. And this nice video by Dr. Magid shows the second surgery for recurrent submacular hemorrhage.
This is a secondary hemorrhage after less than 3 weeks, 3 months, sorry. And this is intraoperative findings of submacular hemorrhage. We can find that the submacular hemorrhage become more massive and huge, both in size and height. So I decided at that point to do a surgical removal of this hemorrhagic mass together with the CNV. Keep in mind that the recurrence very rapid with the within less than 3 months. And as well as the vision didn't improve more than 0.05 in the best situation after repeated injection and dryness of the macula, and even after previous surgery with TBE, and I injected in the first surgery at the end of surgery AntiVEGF. So I do a retinectomy, peripheral retinectomy, folding the retina, exposing the mass, deliver it from behind, from underlying retina, and remove it with highest vacuum and low cutting rate with using a ketome. And I plan after that to do a batch graft from the choroid. And so after the removal of the hemorrhage and cleaning the media, surrounding media from the residual hemorrhage, I spent some time to searching for a good area of the choroid to make harvested graft from the choroid to do a batch graft. But unfortunately, I found that the choroid wasn't healthy. As we see, there is a whitish patches scattered all over the choroid, which means that the RBE wasn't healthy. And this is IOCT indicates that there is no residual CNV, and also the RBE was removed. So I finalized my surgery. I regret to do a batch graft from the choroids and do laser and silicone oil at the end of surgery. And finally, after 5 months now, and the patient still siliconized, and the best corrected visual acuity was 0.05, which is the optimum visual gain, even with drying of the macula after several injections and also after the first surgery. And as we see, we get rid the mass, the patient no need more injections, and this is the OCT after the surgery.
So basically, you fought the battle till the end, I believe. Dr. Mughazi, would you like to comment on recurrent vitreous hemorrhage in cases of hemorrhagic CNV?
Well, usually it happens when you when you ignore the follow-up of those patients, or maybe in some patients who ignore the follow-up themselves. And just the message is, though this is an active disease, if you do the vitrectomy or not, so either do a PR, treat and extend like Dr. Sharif does, or instruct your patient about the importance of to commit to the follow-up. But actually, you cannot prevent it. Sometimes the hemorrhage happens even after a few days of the injection, of intravitreal injection of anti-VEGF. So it's just an aggressive disease. You have to deal with it like that. Dr. Sharif, please, because there is no more time for us.
Okay.
Have, one more case.
I have one more case. Actually, it's a narrated video by Dr. Magid Mikhail. He said it would be a nice case to share. He is a 70-year-old male patient. He's not Egyptian, came with history of diagnosis of retinal detachment in the left eye, and the vision in the left eye was hand movement. And here is the video by Dr. Magid Mikhail.
This 70-year-old patient with affected vision for 7 months, and B-scan reported that there was vitreous hemorrhage with long-standing retinal detachment. And after removal of the organizer blood, I surprised when I found this huge mass wound under the macula, and I realized that it could be scored CNV with mixture of organizer blood and tissue. So I couldn't find any alternative rather than I have to remove this mass with choroidal batch graft. So I performed peripheral temporal retinopathy more than 180 degrees to detach and fold the retina, exposing this huge mass and try to dislodge this mass from underlying choroid and the overlying retina to deliver it out and remove it safely without injury to the underlying or overlying structure. With good grip and manipulation of retinal forceps, I succeeded to deliver this mass out and place it on the surface of the retina, and then inject a bubble of PFC to displace this mass away from the retinal surface. I tried to remove the mass using an occutome by increasing the vacuum to the highest and lower the cutting rate, but it failed. Also, I tried to use the fragmentome after enlargement of sclerotic site, but unfortunately, it failed also to remove this huge old mass. So I decided to consider this huge mass as a large foreign body. So I used the foreign body forceps after the enlargement of sclerotic site and succeeded to grasp this mass using a foreign body forceps, but it was so big to stuck to the internal sclerotum. So I enlarged the sclerotum using a radial incision with MUR plate and tried with the two forceps to deliver it from this enlarged sclerotum, but also it was too big. So I extended the circumferential incisions of sclerotomy to make it so big and using two forceps, and finally I succeeded to deliver this huge mass. And after delivering of this huge mass, suturing was performed to close the enlarged sclerotomies. And then I continued my surgery by cleaning the area of hemorrhage behind this huge mass, removal of any blood clots that present underneath the retina, and then exposing the area of previously removed choroidal neovascular membrane and the injection of perfluorocarbon liquid to maintain coating of the retina. Then choroidal patch graft was harvested from the upper temporal area using forceps in one hand and scissor in the other hand, and placing this patch graft overlying the area of the macula, especially the pupillar macula, and then removal of BFO from underneath the retina with flattening of the retina by injection of BFO over the optic nerve head, and finally laser was performed, followed by cerebral ion tamponading at the end of surgery. This step.
Thank you, Dr. Maged. It's a very elegant surgery. Finally, to conclude the session, I need a message from Dr. Sharif Babi. When to decide to go for surgery in patients with submacular hemorrhage and TNV, would you consider the vision, the amount of hemorrhage, the duration, the other eye? What is the message we need to deliver in surgical management of hemorrhagic CNV? You are muted, Dr. Sharif. Please unmute.
The message is that for submacular hemorrhages related to wet AMD, duration is very important, and the thickness of the hemorrhage. If the duration is less than 1 week, the prognosis is quite good, and the hemorrhage has to be quite thick in order to benefit from the surgery, because if you have thin hemorrhage, you can just do an injection. So this is very important. The duration of the hemorrhage and the thickness of the hemorrhage has to be quite thick, and the level of the hemorrhage has to be subsensory and not sub-RP. These are the three factors I look at. If you have the 3 factors there, I would go for surgery.
Thank you, Dr. Sharif. I believe Dr. Moghazi, you can conclude the session.
Thank you, Rania, very much, and thank you for all the speakers. And now I have the pleasure to invite Dr. Ahmed Souka for his presentation as a part of Bayer Symposium. Dr. Ahmed Souka will talk to us about the V protocol, which is a very interesting DRCR-net protocol, talking about the patients with very good visual acuity. Some of those patients we see in our everyday practice, and I'm sure Dr. Souka will guide us through how to approach those cases. Fadal, Dr. Ahmed.
Thank you, Dr. Moghazi, for having me with you. It's a real pleasure to join any webinar where Watany Eye Hospital is involved in. Today, I'm going to talk very shortly about how we treat the high visual acuity DME patients in our clinics based on the results of the DRCR network protocol V. Why did the DRCR try to study this? Because they discovered that we did not have this cohort of patients studied alone, how they behave and how should we treat them. So how did previous patients look like? Starting from ETDRS, where we compared focal or grid laser to observation, they had lots of patients, actually in the area of 40% of their patients, who had visual acuity better than 6/9, better than 20/30, in the area of 20/25 or 20/20, which is more than 6/9. And within these groups in the study, 27% of those who received laser had a drop of vision of 5 letters. And 40% of these patients dropped 5 letters when they were only observed and not treated by laser. So this is how they looked when you compare the results. That it was in the area of 40%, with laser it was in the area of 27%. And then when they tried to look at this cohort of patients in the and the third laser was used, and the patients who were better, how many lost 5 letters or more? Only 5%. So they said, of course, injecting obviously prevents this loss. So what strategies did they study in protocol V? Simply, if you would inject patients who are having center-involved diabetic macular edema with very good vision, or giving them some laser and only injecting when the visual acuity drops to 20/40 in the area of 6/12, or you just observe, no laser, no treatment, and only add your anti-VEGF injections when the visual acuity drops to 6/12 or 20/40. So how many patients were involved? In the area of 200 and something in each group. Overall, so it's close to 700 patients. If we translate these regimens, who will be compared in the study, to our practice in real life, this means we would observe the patient, do nothing, until the visual acuity drops to the study levels, 20/40. But we rescue him by anti-VEGF if it drops. And some would adopt the idea of why not putting laser and observe the patient for visual acuity. If it drops, we again rescue it by anti-VEGF. And others would say we'll start early with anti-VEGF injections, get rid of the edema, and improve the vision. So this means we have to monitor the patient using only vision, not OCTs. You are not looking at more edema on OCT. You're only seeing how good the patients see. And if it drops to 6/12, then you start injections. And you never give laser and say this is good treatment for high visual acuity patient. No, you still have to monitor visual acuity and give injections if it drops. How did they find these 3 strategies in comparison to each other? The most important question at first was, how many of these patients would lose vision because they are already high vision patients in any of these 3 strategies? And they were all the same, no statistical significance. So utilizing any strategy of these does not lead to loss of vision. It's always in the area of 17% on average. And the 3 strategies were the same. How many gain vision? Maybe one strategy is better than the other and we should go for it for visual gain. But again, after 2 years, you could see that the 3 were statistically insignificant. They had the same vision at the end as regards gain of letters. Of course, starting injections early with aflibercept led to some percentage increase in 27%, but still it was not statistically significant. How did this look on curves over 2 years? By the end of 2 years, everything was insignificant in comparison and they all were the same. But at 1 year, you could see that some patients were better, these who received the injections early. And this is understood because they were treated. Others were still not treated. And some of them would drop in vision and then receive the treatment delayed. But at the end of 2 years, they would all look the same. Did these patients gain vision over the 2 years? Yes, the ones who received the injections did gain vision better than the others over the 2 years. But they all ended up with reasonable vision comparable to each other by the end of 2 years. So, in real life conclusion, this means you can delay your start of treatment until vision drops. You're not losing any patients or any vision. Monitoring the patient became very important. You have to look for the visual acuity and never tell the patients we're not going to inject. We'll only tell the patient we will inject if the edema increases and your visual acuity drops, but you're actually monitoring vision. Symptomatic patients, in my opinion, should get some relief if they cannot function in the society. If you look at the anatomy, you find something very exciting here. At 1 year, the aflibercept group has, of course, better anatomy. But at the end of 2 years, the anatomy was similar in the 3 arms. Why? Because the patients who did drop in vision received injections and improved their anatomy. So the overall of the group, in cases of observation or laser at the start, still looked the same on OCT after 2 years because you treated the ones who behaved badly. So observing a laser does not improve the anatomy in the first year, but after you inject, of course, there will be some significant improvement. Okay. One last important point, I think, why not give the laser? Maybe if the patients drop and you give injections, you might give less number of injections than starting early with injections or observing and not giving injections laser to reduce the number of injections. Unfortunately, the patients who did receive injection after laser received the same average number of injections to reach the same good endpoint. Again, it's in the area of 8 injections over the 2 years. So laser did not show any benefit at all, even in the number of injections. So in summary, and I have my name on the summary because it's not the DRCR, it's my summary of what they explained to us, that the 3 surgeries are not causing loss. And injections are used only if the vision drops. It's not a monotherapy of laser, for example. Injections will be added. Most arms were good as regards vision at 2 years in whatever strategy you adopt. Importantly, if you delay injections, 3/4 of laser group did not receive any injection. 2/3 of observation group did not receive any injections. So injecting all patients would make us give unnecessary injections in the area of 65-75% of patients. So I wouldn't actually inject everybody in the high visual acuity DME patients. Laser is becoming useless, it's not reducing the monitoring burden. You still have to monitor vision. Not less patients are injected in comparison to observation. So you're not reducing the number of patients here. Also, not less injections are used in the follow-up when the vision actually drops. Again, it's the 8 injections. Again, these are my conclusions, not the DRCR. They left conclusions to us. Asymptomatic patient, not complaining. You discovered by accident on OCT that he has edema. You do not inject. You should, in my opinion, observe. The patient's not complaining. And if the vision drops to 20/40, in the area of 6/12, you can start your injections. If the patient is symptomatic, I would inject early because it's expected to have the same number of injections in the area of 2 years, and the patient is complaining and is not functioning well in the society. This was a publication in JAMA, of course, of the DRCR group of study collaborators and so on. And this explains how we treat high visual acuity DME patients according to new evidence-based medicine. Thank you, and thank you very much for listening. I hope this was somehow beneficial to our audience, and it was nice to have you all having me in your webinar. Thank you.
Thank you, Mohammed. Thank you very much.
See you, Vish.
Very nice presentation, very protocol that we have to follow in our practice. So I guess Dr. Mughazi has disappeared from the webinar. So yeah. I guess we would like to thank you, and we would like to conclude this Retina session for tonight. We stayed quite long, and we were really happy to have 2 eminent speakers as guest speakers, Dr. Magdi Musa for the Novartis Symposium, and Dr. Ahmed Souka from Alexandria for the Biosymposium. And also I'd like to thank all the panelists, Dr. Magid Mikhail, Dr. Mughazi, and thank myself as well, and also all the speakers, Dr. Rania and Dr. Dina. They did a great job, and I hope we didn't stay too long. But again, these are bedtime stories, so we have to start late. And I think it's time to say good night. Dr. Mughazi, the microphone is for you.
Thank you very much.
Thank you.
And thank for everybody, and hope to see you in the coming nights of the Watany Web Week. Still have till next Thursday, inshallah. Thank you all, and good night.
Thank you. Good night.